friends, welcome to this November INICET 2021 Pediatric Recall session, in which I will be discussing some questions which we have collected from our students. They've been able to recall some of the questions and the options of those questions. Based upon whatever I could get from those recall, I will be discussing those questions here. I again remind you that this is basically what our students have been able to recall. So options sometimes may be a little different, and that might change the whole answer to the questions. But based upon what we have been able to collect, let us discuss those pediatric questions. The first question that was asked, one of those questions that was asked in pediatrics, from pediatrics in this November INICET yesterday, was match the following, and these were milestones that were given, and we all know that milestones are very, very important. I have always been repeating in my classes that milestones are very, very important questions that are more often than not asked usually either in NEET PG or AIMS at least once every year. So we had one, I think, question on milestones in NEET PG this year also, and we have this milestone question here also. Here they had given two columns and they wanted us to match the columns. So the milestones that they have given are all the milestones that we have discussed in our classes also and discussed in our pediatric eGurukul app also. So the milestones that were given was the social smile, pincer grasp, walks 1 to 2 steps, and transfers objects. And as I've already told in my classes many times, this is just a snapshot of our eGurukul notes, which is prepared from our pediatric eGurukul video. And you can see we have discussed most of these milestones in detail. And when it comes to discussing about walking, well, child starts walking with support at the age of about 10 to 11 months. And by about 13 months to 15 months, that I always tell, the child is able to take some walks about 2 steps, 3 steps without holding on to any support. Similarly, I have also discussed that the child transfers objects from one hand to another hand approximately between 5 to 7 months of age, which is around 6 months of age on an average. The child can transfer objects from one hand to another hand. Regarding the pincer grasp, that's a very important type of a palmar grasp where the child holds objects between the thumb and the index finger. And as I've already told many times in my classes, the immature pincer grasp develops at the age of 9 months, which turns into a more mature pincer grasp at the age of about 12 months. So somewhere around 10 months to 11 months, the pincer grasp from an immature pincer grasp turns to a mature pincer grasp. And then we have discussed about social milestones, among which we have discussed about social smile. And I have discussed that in social smile, the child starts developing a social smile by the age of about 6 to 8 weeks, which is roughly around 1 to 2 months of age. So if we come back to this question, if you would have gone through these notes, I don't think there would have been any difficulty in answering this question. So social smile, I will answer it as 1 to 2 months only, 6 weeks to 8 weeks. Pincer grasp, as I told you, immature pincer grasp develops at the age of about 9 months, but it turns into a mature pincer grasp at the age of about 12 months. So pincer grasp, I will mark it as 9 to 11 months. Walking 1 to 2 steps, as I told you, the child starts walking at the age of about 10 to 11 months, but that is holding on to a support. When is the child starts to walk without holding on to any support? It's about 13 to 15 months of age. So I think the best answer here will be 12 to 13 months. And as I've told you, the child transfers objects from one hand to another hand somewhere between 5 to 7 months of age. So I think this matches. So I would say 1 for A, 2 will be C, 3 will be D, and 4 will be B. So this is according to the arrangement in my question. Based upon how the choices were arranged in your exams, you could have easily answered. Basic premise of whatever I'm saying is that if you would have gone through our classes, which I'm sure you have all gone through, you would have been able to easily answer these milestones that were asked in the exam. So this was regarding question number 1. Then another question that was asked was on a congenital heart disease, where they asked which congenital heart disease has equal saturation. Now there is some discrepancy in what students are saying. some students are saying they had asked which congenital heart disease has equal blood distribution, but I think it makes more sense to say equal saturation in all the chambers of the heart. And the choices that they're given was tetralogy of Fillet, total anomalous pulmonary venous connection or total anomalous pulmonary venous return, transposition of great arteries TGA, and tricuspid atresia. So again, we have discussed about these congenital heart defects in detail in our classes also and in our eGurukul app also, and these are again the notes of eGurukul app. What makes sense to me is that if you would have known the basic mechanism by which TAPVC or TAPVR functions, I think you would have been able to answer the question. According to me, TAPVR should be the best answer here, or TAPVC should be the best answer here. The reason is that what happens in a total anomalous pulmonary venous return or a total anomalous pulmonary venous connection is that all the four pulmonary veins, they drain into the right atria in comparison to the left atria. So they are opening into the wrong chamber. And since all the four pulmonary veins are opening into the wrong chamber, we call it as a total anomalous pulmonary venous return. Now, this same blood, which is desaturated blood, some of it enters through the foramen ovale, or if there is an ASD present, some of it will enter into the right atria, while the remaining part will go down into the right ventricle. The part that has entered into the left atria will then go into the left ventricle, and that will be the part that will be maintaining the systemic circulation. So the systemic circulation obviously will contain desaturated blood. So this will go into the aorta, while the remaining blood which has entered into the right ventricle will be entering into the pulmonary artery. So broadly, if we will be seeing broadly, the right atria, the right ventricle, the left atria and the left ventricle will be all getting the same desaturated blood. So the saturation of all the four chambers in a total anomalous pulmonary venous return, according to me, will remain the same, because it's the same blood, which is desaturated blood, entering into the right atria, which is getting distributed into the left side of the heart also and into the right side of the heart also. So according to me, for question number 2, the best answer should be total anomalous pulmonary venous connection. Again, based upon whether it is equal saturation. If there is some other word which was put in this question, then probably that answer might be different. But I think the best answer here will be total anomalous pulmonary venous connection. And we have discussed this congenital heart disease in detail in our classes also and in our eGurukul app also. So I think you should have been able to, if you would have known the mechanism I have told you, this is the mechanism I have discussed in my eGurukul app also, the mechanism by which TAPVC, the supracardiac TAPVC especially functions. So if you would have known this mechanism and you would have drawn this mechanism somewhere, I think you should have been able to easily answer this question. Coming to question number 3. Now question number 3 says, at what age does a baby attains half the height of an adult? And the choices that they have given, which again, according to the students, some of the students, the recall options have been 12 to 18 months, 18 to 24 months, 28 to 32 months, and 32 to 36 months. Again, the answers may differ, but this is what some of the students have been able to recall. And we have discussed again in our eGurukul app how the length of the child increases. And I've told that the length of a child at birth is 50 centimeters, while the child's length becomes 75 centimeters at 1 year and about 85 centimeters at the age of 2 years. So by the age of 2 years, most children have attained a height of about 85 to 90 centimeters. Now considering the average height of an adult will be somewhere around 160 to 170 centimeters. Some may be a little taller also, maybe about 180 centimeters. But in most cases, the adult height will be somewhere between 160 to 170 or 175 centimeter. So going by that standard, half of that adult height, I think, should be attained between 18 to 24 months of age. Because by 24 months of age or by 2 years of age, most children have attained a height of 90 centimeters, double of which is 180 centimeters. And by 1 year of age, most children have attained a length of 75 centimeters, double of which is 150 centimeters. So somewhere between 18 to 24 months of age, I think most children would have attained a height which is half the height of an adult. So between 18 to 24 months of age, most children would have attained a height which is half the height of an adult. Considering the average height of an adult to be somewhere around 160 or 175 centimeters, 160 to 175 centimeters, half of that height, according to me, which is if I say it 160 to 180 centimeters also, half of this, which is around 80 to 90 centimeters, is attained somewhere between 18 to 24 months of age. So therefore, according to me, the best answer here should be 18 to 24 months of age. One-year-old child has attained a length of 75 centimeters and a 2-year-old child has attained a height of 90 centimeters. So somewhere between 1 to 2 years, these children move from a length of or a height of 75 centimeters to a height of 90 centimeters. Till 2 years, we normally say the length. After 2 years, we normally say the standing height of a child. Coming to the next question, which is a question on immunization. Some of these questions may overlap with other subjects, so maybe might have been taken by some other faculties also. But let me discuss the questions which I felt are questions involving pediatrics, and therefore I've discussed those questions in my this recall video. Now this question says hepatitis B subunit vaccine is derived from which antigen, which is a very simple question. Again, in my immunization chapter in pediatric eGurukul app, I have discussed that the recombinant vaccines, one of those vaccine is a hepatitis B vaccine. So hepatitis B vaccine is a vaccine which is prepared by the recombinant DNA technology and involves hepatitis B surface antigen. It is prepared by the recombinant DNA technology. It is stored at a temperature of about 2 to 8 degrees centigrade. It should never be frozen. It is stored at a temperature of about 2 to 8 degrees centigrade. And this vaccine in the national immunization schedule is given at birth, is given at 6 weeks, 10 weeks and 14 weeks, often as a part of the pentavalent vaccine. So this vaccine is often given as a part of the pentavalent vaccine. Although there is quite a lot of data to show that if this vaccine, hepatitis B vaccine, is given in a 0-1-6 months schedule, it is considered to be almost equally efficacious. But usually in the national immunization schedule, it is given as birth, first dose, for horizontal, to prevent any horizontal transmission. So birth, then at 6 weeks, 10 weeks and 14 weeks. At 6 and 10 and 14 weeks, it is given as a part of the pentavalent vaccine. So I think this is a pretty simple question. Hepatitis B subunit vaccine is derived from which antigen? So it usually includes the hepatitis B surface antigen, which is prepared by the recombinant DNA technology. Coming to question number 5. Now question number 5 again is a question that I've discussed in my classes also and in my app also, and those who have been students in my classes and who have gone through the app, pediatric app, should be able to easily answer this question. The question says dexamethasone given to a mother for fetal lung maturity in the following dose and duration. Now, if a child is born premature, and normally we say prematurity is earlier than 37 weeks, but if a child is born earlier than 34 to 35 weeks, the surfactant production normally peaks at about 34 to 35 weeks of intrauterine life. So any child who is born earlier than 34 weeks or 35 weeks of intrauterine life is likely to have less amount of surfactant production. So these children naturally will have some degree of surfactant deficiency, which is likely to predispose them to the develop respiratory distress syndrome or hyaline membrane disease, a disorder which is primarily present in premature infants and is due to surfactant deficiency. Now, therefore, to increase or enhance lung maturity in all newborns who are born premature, the guidelines are that women who are between 24 to 34 weeks of pregnancy and who are going to give birth to a baby in the next 1 week, corticosteroids should be given. Corticosteroids are one of the best methods to enhance surfactant production and thereby hasten fetal lung maturity. Now, two corticosteroids are normally recommended. One is betamethasone and the second is dexamethasone. The salt of betamethasone that is recommended to pregnant women to enhance lung maturity is betamethasone acetate phosphate salt, which is not available in India. As a result, betamethasone directly is not recommended in India, and I'm not very sure, but possibly the most commonly used corticosteroid for enhancing lung maturity, which is given to pregnant women in India, I think is dexamethasone. Now in my app, again, this is again a note from my app, you can very clearly see that I have discussed that all premature deliveries where the woman is giving birth to a child between 24 to 34 weeks or 24 to 36 weeks, the guidelines are 24 to 34 weeks but may be extended to 36 weeks. Here the dexamethasone or betamethasone should be given. Now, as I said, the betamethasone salt that is usually given is betamethasone acetate phosphate salt, which is not available in India. The dose of betamethasone is 12 milligrams intramuscularly once daily, 2 doses. Dexamethasone 6 milligram intramuscularly, 12-hour, total of 4 doses are usually recommended. So because betamethasone is not recommended here because that salt is not available, betamethasone acetate phosphate salt. So dexamethasone is more commonly given to pregnant women. And this dose is, as I told you, 6 milligram intramuscularly, 12 hourly, given for a total of 4 doses. That means 48 hours. So 6 milligram 12 hourly for a total of 4 doses is the recommended dose to enhance lung maturity in children who are born premature. Obviously, where there is a history of frank chorioamniotis, this should not be given, corticosteroid should not be given, but otherwise this is one of the best ways to enhance fetal lung maturity, especially where you expect that the child, because of being born premature, is likely to develop a hyaline membrane disease. And apart from helping in enhancing lung maturity, antenatal corticosteroids given to pregnant women can have many other beneficial effects on premature infants. It can reduce the risk of NEC also. It can reduce the risk of severe intraventricular hemorrhages also. It can reduce hospitalizations and deaths also in premature infants. So there are many benefits of giving antenatal corticosteroids in pregnant women. Coming to question number 6. Question number 6 is a question where they say neonate presents with seizures. On CSF examination, the child has meningitis. Which of the following is the most likely causative agent? Now, I'm not sure about what the other choices was, but what is most important was that this choice was there. Now, I'm not sure whether gram-negative bacterial choices were there or not, but I've discussed in my apps also that when it comes to pediatric meningitis, especially in neonates, first 2 months, including neonates, worldwide the most common cause of neonatal meningitis is group B Streptococcus or Streptococcus agalactiae. But in India, the most common cause usually are gram-negative bacteria, particularly E. coli. Although Klebsiella, Staphylococcus, which is not gram-negative, gram-positive, but Staphylococcus and Listeria are also some of the causes which can cause neonatal meningitis. But the most common cause usually worldwide of neonatal meningitis is group B Streptococcus or Streptococcus agalactiae, while gram-negative Enterobacteriaceae, particularly E. coli, happens to be the most common cause of neonatal meningitis in India. So I asked the students specifically whether E. coli was one of the options. They could not recollect E. coli being one of the options, but Streptococcus agalactiae definitely was one of the options. And Streptococcus agalactiae is the other name for group B Streptococcus. So the most common cause, at least unless and until I know what other options were there, Streptococcus agalactiae should be the best answer here. So basically what they are trying to ask is the most common cause of neonatal meningitis. And worldwide, they are not specifically asking in India. Worldwide, the most common cause definitely is group B Streptococcus or Streptococcus agalactiae. Coming to question number 7. Question number 7 says, which of the following can cause neonatal seizures? And the choices that they had given was hyponatremia, hypomagnesemia, hypernatremia, and hypocalcemia. Now, this is a little tricky question to answer. See, normally in my classes I always say that the most common causes of neonatal seizures are 5H and 1I. Hypoglycemia, hypoxia, hypocalcemia, hypomagnesemia, hemorrhage in the brain, and infections, particularly meningitis. But that does not mean that these are the only causes. Now, regarding hyponatremia and hypernatremia, that means dyselectrolytemia. If you actually see, this is from the Manual of Neonatal Care, which is Cloharty and Stark, and this is one of the most respected manuals of neonatology for MD Pediatrics. Post-graduation pediatrics, this is one of the most respectable manuals. And please remember here that the most common causes of neonatal seizures mentioned here are an exhaustive list, which includes HIE also, which includes focal infections also, such as arterial and venous infections, includes intracranial hemorrhages also, I just now mentioned, that includes various types of infections also, includes various CNS malformations also. Among metabolic disorders, hypoglycemia, hypocalcemia, and hypomagnesemia are the most common disorders which lead to neonatal seizures. And they do not mention about hyponatremia and hypernatremia as causes of neonatal seizures. If you in fact see the other causes that they mentioned, inborn errors of metabolism, including amino acidopathies and organic acidureas and mitochondrial disorders, and then some epilepsy syndromes are there. Benign familial syndromes, benign idiopathic neonatal convulsions, benign familial neonatal convulsions. But broadly speaking, if you see, they do not mention about hyponatremia and hypernatremia here. And it's a very exhaustive list. This is the Manual of Neonatal Care, Cloharty and Stark. However, in Nelson's textbook of pediatrics, they have given a very, very long list. And in that long list of causes or etiologies of neonatal seizures, they mention both hyponatremia and hypernatremia can be causes of neonatal seizures. Even in other manuals, they have not mentioned hyponatremia and hypernatremia as causes of neonatal seizures. Clearly, among the metabolic disorders, hypoglycemia, hypocalcemia, and hypomagnesemia are the causes of neonatal seizures which are more common. But when an investigation for neonatal seizures is done, serum sodium, it's mentioned in many places, serum sodium should be investigated. So why are we trying to investigate serum sodium if hyponatremia and hypernatremia are not causes? According to me, they can cause neonatal seizures, although very, very rarely. The common causes will always remain hypoxia, hypoglycemia, hypocalcemia, hypomagnesemia, hemorrhage in the brain, and meningitis. But serum sodium needs to be investigated along with other investigations when a neonatal seizure occurs. So please remember that according to me, and again this might vary from a faculty to faculty, I don't know, this thing might vary. There might be some faculties who say something, other faculties say other thing, and you are seeing the Manual of Neonatal Care of Cloharty, which is one of the most respected manuals of neonatology, does not even mention about hyponatremia and hypernatremia as causes. But in Nelson's textbook of pediatrics, I've checked, there is a line saying hyponatremia and hypernatremia can be causes of neonatal seizures. Going by that account, I feel the best answer possibly should have been all the four: hyponatremia, hypernatremia, hypocalcemia, hypomagnesemia. So I would have answered all the four. Again and again, I am saying hyponatremia, hypernatremia are not common causes, and most books do not even mention about them. But that does not mean that they should not be counted among the rarer causes also of neonatal seizures. And since they are asking hyponatremia, hypomagnesemia, hypernatremia, and hypocalcemia, and one choice does mention all the four, I think the better answer will be all the four. Hyponatremia also, hypernatremia also, hypomagnesemia also, hypocalcemia. But this is according to me. But if you ask me directly, sir, which are the more common causes, I would not mention directly hyponatremia and hypernatremia because they are much rarer causes. Immediately my mind will go to hypocalcemia, hypomagnesemia, hypoglycemia, hypoxia, hemorrhage in the brain, and infections. The most common cause overall is hypoxia, hypoxic ischemic encephalopathy, most common cause of neonatal seizures. So according to me, if you are given question number 7 and according to Nelson's textbook of pediatrics, probably all the four, 1, 2, 3, 4 can be causes of neonatal seizures. Although hyponatremia, hypernatremia are much rare and do not find a mention in many textbooks also. Coming to question number 8. Question number 8 mentions about a full-term normal vaginal delivery neonate at 14th day presents with bilateral conjunctivitis. Now, this is quite possible that your optha for faculty might have discussed this, as this appears to be a direct question of ophtha and pediatric integration. And here the child is in addition presenting with bilateral opacities. I think this is a very easy question to answer. Answer should be chlamydia here. Chlamydia trachomatis is one important cause of neonatal pneumonias also and neonatal conjunctivitis also. The inclusion conjunctivitis of chlamydia normally occurs between day 5 to day 14. So that's the inclusion conjunctivitis. The day of presentation, almost around I think 5 to 30% of women who have active chlamydial infection during pregnancy. So about 5 to 30% women during pregnancy have active chlamydial infection and may expose their neonates to develop a variety of problems or complications due to this infection, chlamydial infection. One of that problem is pneumonia, the other problem is conjunctivitis. As I told you, the inclusion conjunctivitis that occurs in neonates normally presents between day 5 to day 14. Your ophtha faculty will be better, more expert to answer about conjunctivitis. However, pneumonia can also be a presentation of chlamydia trachomatis. The typical presentation of pneumonia is somewhere between the first month to 3 months of life. Now, this 14th day child presenting with bilateral opacities, that's not the typical presentation. Normally, the pneumonia that present in these cases will be somewhere between first month to 3 months. It causes an atypical type of a pneumonia characterized by almost afebrile child but marked tachypnea and cough. So cough and tachypnea will be very marked. There might be presence of alveolar infiltrates and interstitial infiltrates because this is a typical presentation of an atypical pneumonia caused by chlamydia trachomatis. But since this child is presenting with bilateral conjunctivitis also and is presenting with bilateral opacities also on the chest x-ray, I believe this is chest x-ray what students had told me. I'm not very sure. I believe this is chest x-ray which the students have told me. So I think the best answer would be chlamydia trachomatis. I go according to chlamydia trachomatis, taking into account that this is a chest x-ray showing bilateral opacities and bilateral conjunctivitis which is present. Otherwise also this is the 14th day of presentation and 5 to 14 days is the typical time of presentation of chlamydia trachomatis. So question number 8, the best answer will be B. Question number 9, again this might have been taken by some other faculties also. It's a very pretty simple question. In which of the following disease collagen is affected? Answer clearly is scurvy. We have discussed in our classes also, in our app also, and I will not go into the details, but scurvy we have discussed in detail and we have told that vitamin C has many functions, but one of the important functions of vitamin C is collagen synthesis. So when vitamin C is deficient, collagen synthesis obviously is affected, which can lead to a number of problems, particularly the problem of osteoid formation. Because osteoid includes collagen framework, the osteoid formation will not be normal, while mineralization will be normal in cases of scurvy. So these children of scurvy will present with a variety of presentations, which again I mentioned in my app, which will include initial presentations of decreased appetite, irritability, and later on there might be presence of hemarthrosis, petechial spots, bleeding from the gums, bone pains, including pseudoparalysis, which is a very characteristic finding of both syphilis also and scurvy also. Rosaries are present in these cases. Scorbutic rosaries usually uh, dome are angular rosaries or sharp angular rosaries, while rachitic rosaries are usually dome-shaped rosaries. So rachitic rosaries are round, while scorbutic rosaries are sharp and angular. So I think the this question answer is quite clear. Which of the following disease collagen is affected? It is scurvy. Coming to question number 10, most common cause of urinary obstruction in male. Some say it was fetus, some say it was neonate, some say it was children. It is very clear the answer is a posterior urethral valve. I've discussed this again in my classes that the most common cause, this is again from our app, the most common cause of low urinary tract obstruction, I'm sorry, in male infants is a posterior urethral valve. There is an obstruction which is present in the prostatic urethra, which obstructs the prostatic urethra and can lead to a variety of complications, including hydronephrosis, hydroureter. There will be a vesico-ureteric reflux, and all these problems will lead to a child not passing urine normally after birth. So urine passing in drops and suprapubic distension is a common presentation of children who have posterior urethral valve. It's the most common cause of lower urinary tract obstruction in a male infant. The most common cause of urinary tract obstruction occurring in the bladder neck area or in the bladder outlet area. We also call it as a bladder outlet obstruction. The place of obstruction is the prostatic urethra, but we also call it as a bladder outlet obstruction. So it's the most common cause of bladder outlet obstruction also in male infants. Now, just when I'd already prepared for this, there was a student who had mailed me these questions. One of the students had also told me that there was a question that was probably asked on splenomegaly also. That was question number 11. In which condition splenomegaly is not present? In which condition splenomegaly is not present? And the choices they had given was included I think leukemias also, included lymphomas also, and included aplastic anemia also. And this again is a very simple question with a very simple answer. Aplastic anemia is clearly the condition which is not associated with splenomegaly. Leukemias, lymphomas can be associated with splenomegaly, but aplastic anemias are not usually associated with splenomegaly. There was a question on chloroma also, which I think our path faculties has taken. So I will not be taking that question on chloroma, which is commonly seen in AML M2 subtype. And I think peripheral smear, including the particularly seeing the leukocytes, are one of the best ways to diagnose chloromas. But anyway, I think your path faculty sir has taken that question in his recording, so I won't be discussing that question. In case there are any other questions of pediatrics that are present, I think there must be around 15 questions. I have already discussed about 11 questions. In case there are any other questions, please feel free to put it on the Facebook Premier page and tag me, or you can telegram that question to me. I will be more than happy to give the answer to that question. There were some one or two questions which the students were telling me more of pediatrics, but they could not really recall the correct question or even the options of that question. So it was futile to put that question here on in this session. But please feel free to put that question in my Telegram page. I will be more than happy to answer that. If there are any other pediatric question or any other pediatric query you have, please feel free to put that question. Otherwise, also you can put it on the DBMCI Facebook Premier page, and I will be happy, and tag me, and I will be happy to answer that question. So I hope this session has been helpful to you. One more information, I think the DBMCI is also launching this LMRP from about, I think, the 15th of November. So you can purchase your LMRP in case you want. It will be a very helpful guide for your NEET PG, upcoming NEET PG exams. We have all tried to summarize all our app content in those LMRP. LMRP for pediatrics also will be available. I've tried to put all that content, 65 to 70 hours of app content, in about, I think, 20 hours, 15 to 20 hours. So it's a very concise LMRP which you should find useful for your upcoming NEET PG exams. So thank you very much, and I wish you all the best for your future exams and for your results also of INICET. And as I told you, in case you have any queries, please feel free to connect anywhere where I'm available, and you can ask me that question. Thank you and goodbye.